Today we're going to talk about treatment of type 1 ROP. Treatment of ROP has evolved across the years, and the first big study that looked at how to treat ROP was the cryo-ROP study. It was published in the 1980s. It established a time frame to treat ROP, and it established cryotherapy to treat the cryotherapy to the periphery of the retina to treat retinopathy of prematurity. In the early 2000s, the early treatment of ROP study came and replaced cryotherapy with laser and provided as well an earlier time frame to treat. So instead of treating ROP at threshold disease, they introduced the concept of pre-threshold type 1 ROP. Between 2008 and 2011, the BEAT ROP study emerged and introduced the use of anti-vascular endothelial growth factor as a method to treat retinopathy of prematurity. So these are basically the three strategies that can be used to treat ROP, but in reality, the role of cryotherapy has reduced significantly, and laser and injections of anti-VEGF remain the two methods to treat this disease. The pathophysiological basis to understand the pathophysiological basis for treating ROP, we need to understand that the ischemic peripheral retina releases more and more vascular endothelial growth factor. Vascular endothelial growth factor drives the production of new vessels that can contract and result in retinal detachment. Ablating the peripheral retina decreases the amount of retina that can release VEGF, and thus reduces the load of vascular endothelial growth factor in the retina. Injecting anti-vascular endothelial growth factor can block the excess VEGF that in turn would result in ROP. So these are the basis in itself is reducing vascular endothelial growth factor, either by ablating the retina or blocking its action. The indications for treatment are type 1 ROP, known as high-risk pre-threshold detachment. And these include any ROP in zone 1 with plus disease, stage 3 in zone 1, even if there's no plus disease, stage 2 or 3 in zone 2 with plus disease, and of course, aggressive posterior ROP, which is a form of retinopathy of prematurity in which there is apparent plus disease, congestion of the posterior pole, possibly with hemorrhages, without the appearance of frank ROP. Let's talk first about laser, indirect laser ablation. So what's the best type of laser that we can use? We can use a diode laser, which is an infrared laser, or we can use a green laser, like argon or frequency doubled laser. The settings depend on our aim. Our aim is to produce faint grayish scars on the retina. The spot size is dependent on the lens that we use and on the distance from the patient. If we use the 28 diopter lens, we produce larger spots, and so we can perform ablation with a lesser number of spots. If we use the 20 diopter lens, we produce smaller spots, and so it will end up requiring more spots to ablate the peripheral retina. The power and the duration we use are there to produce we use the least possible power and duration to cause faint grayish scars. And you need to titrate them according to the device you have. With the device that we usually start at 400 milliwatts and 300 milliseconds. The interval between each shot and the next should be as short as possible to produce confluent scars, but not too short to allow for adequate ablation. Remember, this is not the same as pan-retinal photocoagulation for proliferative diabetic retinopathy. With PDR, we are aiming to leave one spot's diameter between each spot and the next. With ROP, we want our ablation to be more confluent. So this is an example. This is an infant that we wanted to ablate the peripheral retina for, and you can see here, just anterior to the ridge, we use the 20 diopter lens, which provides a higher magnification and gives us the chance to ablate as close as possible to the ridge without ablating the ridge itself, and makes sure that we don't miss the area just anterior to the ridge. We can then use the 28 diopter to ablate the peripheral retina and use both lenses to fill in. This is what it looks like after we're finished. Regression after laser takes some time. This photo was taken 5 to 6 weeks after patient received the laser therapy. You can see here that the disease was quite aggressive with anteroposterior traction and actually resolved after the laser was performed. Like any procedure, there are possible complications and mishaps that can happen while performing laser. The ET-ROP study reported the following: conjunctival lacerations, retinal, pre-retinal, and vitreous hemorrhages, inadvertent laser outside the intended area, and systemic issues related probably to anesthesia, like apnea and intubation. Other issues including skip areas, technical problems, risks of high myopia, and risks of field defects. So these are some of our images, and you can see here this infant actually developed these hemorrhages on the first day after laser. The hemorrhages resolved with time, and this child is doing quite well right now. Skip areas are a problem that sometimes develop, especially early in the learning curve of laser, when you think you've finished, but in reality, you have a large area here that was not properly ablated. We can overcome this, of course, with proper training and by completing your laser and looking in every quadrant more than one time, and not stopping until you're as sure as you can be that you've ablated as much as possible of the retina anterior to the ridge or anterior to the avascular area. In the avascular area anterior to the ridge. The other method for treatment is the use of anti-vascular endothelial growth factor. And this is the important study that actually gave us anti-VEGF for ROP, was the BEAT-ROP study. So this study used half the adult dose to inject anti-vascular endothelial growth factor. It actually used bevacizumab, half the adult dose. Ranibizumab and aflibercept can also be used for injections, and there are studies looking at both of them as well. The doses can actually be de-escalated, and there are multiple studies that are looking at reducing the dose for fear that systemic absorption may have an untoward complication in the future. Until now, there is no evidence that injecting anti-vascular endothelial growth factor can result in systemic complications, but it is a concern, and that's why dose de-escalation is being looked at. Preparing for injection involves preparing everything, especially if you're off-site. If you're going to inject the infant in the NICU, sometimes these infants are too sick to be transferred to an operating theater, so we are forced to inject them in the NICU. So you need to know exactly what you need, and you need to be prepared. We found that having a team of 4 people at least to inject a single infant is best. So you need a surgeon who's trained and knows what to do. You need someone who's going to restrain the infant, swaddle the infant, because most probably we will be doing this with minimal anesthesia, minimal sedation, possibly without sedation at all, if it's too risky for the infant. You'll need someone who's going to be a scrub nurse or scrub assistant, surgical assistant, who's going to be helping with this, with the instruments, and someone who's not scrubbed, who's helping with providing the topical anesthetic and any other help that might be required during the procedure. You'll need 2 sets of new topical anesthetics, sealed topical anesthetics, speculums, calipers, and forceps to fix the globe. And we are aware, of course, that simultaneous injections are frowned upon or possibly even not allowed in some localities. It's important, of course, for every physician to be aware of what is and what is not legal in their area. We do not advocate anyone to break the law, but at the same time, it's important to understand the logistical problems with ROP. Sometimes it's difficult to transport the infant twice. Sometimes it's difficult for the whole team to go on 2 successive days to treat an infant. And most importantly, sometimes the disease is too aggressive to wait for one eye and then to do the other eye in the next day. So this is a point to be considered when treating retinopathy of prematurity, that you might be forced to treat both eyes simultaneously. In that case, we'll use different sets for each eye, different sterilization for each eye, different batches of medicine for each eye. When we're injecting adults, we usually inject 3.5 to 4 millimeters from the limbus. In neonates, we are injecting 1 millimeter from the limbus. Remember, they are still developing, So they don't have such a large pars plana to allow for safe injection. So we only inject 1 millimeter and only temporarily, because nasally, the pars plana is possibly absent. So you might end up injecting through the retina if you inject nasally. We're injecting temporarily 1 millimeter from the limbus. And remember, the angle of injection is different than adults. With adults, we're injecting towards the posterior pole. In these infants, we're actually injecting straight down. And this is because the anatomy of the infant eye is different than adults. The lens is relatively larger in infants. So if we were to inject towards the posterior pole, there would be a risk of injuring the lens and causing traumatic cataract. Regression after injections is much quicker than laser. And this image was actually taken 1 day after injection. You can see how the plus disease has nearly totally resolved after injection. So within 1 to 2 days, you're supposed to see a good response, especially with resolution of plus disease. But once again, no procedure we do is without possible complications and mishaps. So if you inject too anterior or at the wrong angle of attack, you could develop traumatic cataract. If you're too worried about that and you go too posterior behind 1 millimeter, you could end up injuring the retina and causing rhegmatogenous detachment. The problem with anti-VEGF is that it has been linked to an increase in anteroposterior traction. So if the infant is presenting with a high ridge, there is a risk that this could result in retinal detachment. Endophthalmitis is always a risk with any intraocular procedure. And remember, in these infants, endophthalmitis might not just cause blindness. It could end up being fatal if it causes meningitis and sepsis. The current ROP is a complication. And of course, the potential systemic side effects that we don't know yet enough about. What happens to these children when they grow up? Will this anti-VEGF that we've injected in their eyes cause any systemic problems? A question that remains unanswered. So with recurrence, this infant, one of our infants, had actually received an anti-VEGF injection 4 weeks after we took this photo. We began noticing a recurrence of the plus disease, but there wasn't much ROP. 2 weeks later, there was a development of stage 2 in posterior zone 2. So we re-injected again. And when you see here, the infant actually resolved nicely after the second injection, but then recurred again. There was a recurrence of plus disease and a recurrence of peripheral ROP again. So we ended up doing laser to the periphery. An increase in anteroposterior traction is actually one of the most serious problems that can happen to these infants, because especially, and this infant, when we went back and audited this poor outcome, we found that this infant actually presented quite late. So the late presenting infant, even if they're treated properly, could end up having a very poor outcome. So this is another problem that we need to be aware of when treating ROP. Remember, proper screening, proper examination can help us avoid these really bad situations where you treat and then you have a poor outcome anyway. So what do we do? Laser or injection? The advantages of laser over anti-VEGF injection is that there's nearly no risk of intraocular infection. There's less risk of cataract. Cataract has been found to develop if you use if you use a green laser and the infant still has any remnants of tunica vasculosa lentis, because the blood vessels would absorb the green light and result in cataract. But if you're using a diode laser, there is potentially very low risk of cataract formation. There is a less risk of progressive increase in anteroposterior traction or crunch, and there is a less risk of hypothetical systemic issues of absorption of the drug. Advantages of anti-VEGF over laser is that it can be done under topical anesthesia. So you can actually avoid giving the infant general anesthesia with the risks of apnea and other problems that these infants can end up with if they have general anesthesia. You have less progressive myopia, less risk of field effects, and it's actually technically easier. If you're well trained on injecting these infants, it'll take you a shorter time to master it, and it's much easier and it's lesser learning curve. These images are from the BEAT ROP study. And they wanted to highlight the difference between an infant who received laser and an similar infant who received injection. And they're showing that all this retina was actually ablated with laser. So effectively, the infant does not have good use of all this peripheral retina, while the infant who was given laser had this retina allowed to grow back. Now, there is much debate about this retina that has grown. And there are some studies that actually point out that even these eyes that have had the retina grow will have subnormal function in the periphery of this retina. So their field would also be affected, but the evidence is not conclusive yet. But what is conclusive here is in this image is that there is an avascular area in the periphery. This is very important to remember. If you're going to inject your infant with anti-VEGF, this infant must be followed up until the retina fully vascularizes, or if examination becomes too difficult around 50 weeks post-conceptual age, then it's time to do some laser to the periphery. So the question begs itself, why wouldn't we do laser from the beginning? Well, if you're sure that the infant is going to follow up, then the retina, you've bought the infant some time for the retina to grow to the periphery. This is an example of really excessive laser. And you can see that this infant had a very aggressive posterior disease, but at the same time had mucopurulent conjunctivitis. We could not inject this infant, so we were forced to do laser. But we've put this image just to show how extensive sometimes laser can be, how destructive laser can be. So we've essentially saved this infant's vision, but we've sacrificed a lot of field in that endeavor. One of the best ways to compare different procedures is through a systematic review or a meta-analysis. And we looked at this study, and this study found that anti-VEGF monotherapy has better refractive outcomes, but there is a risk of recurrence and risk of future detachment. The evidence that this study looked at was not of the highest value. So until now, there is no clear-cut answer if one treatment should be done and one treatment should not be done. What do we do in Cairo University Children's Hospital? So we understand that the BEAT-ROP study showed that anti-VEGF was superior in zone 1 disease. So we would probably, for an infant like this with aggressive posterior ROP, we would probably inject this infant first, give this infant a chance with injections first. And even a child like this with posterior disease would still inject first. We give this child a chance with injections first. So when do we use laser? Is there still a role for laser? In fact, definitely there's still a role. So first of all, remember, laser still is the gold standard for treatment, still the gold standard for treatment. According to the evidence, there's no superiority of injections if the disease is in zone 2. So if the disease is in zone 2, you might be forced to perform laser because it has the highest level of evidence. And sometimes you're forced to do that, especially if you are not sure that the infant will follow up, if follow-up is doubtful, or if the infant has a contraindication for injection, like, for instance, the presence of severe mucopurulent conjunctivitis or nasolacrimal duct obstruction, whereby injections could result in fatal endophthalmitis. If your infant is presenting with a high ridge, sometimes we would consider laser, for fear that injections could cause crunch or increase anteroposterior traction. If you've had 2 recurrences, in our practice, after the second recurrence, if we've injected the infant twice, we'd probably end up doing laser. There is some evidence of centers injecting 3 and 4 and 5 times, but in Cairo University, we usually reserve the laser for the second episode of recurrence. And finally, if the infant fails to vascularize and they've reached an age where it's too difficult for you to continue screening, so imagine a 50-week-old infant is a large infant, it's a big infant, probably at that time screening is going to be very difficult. So we would, if the infant has failed to vascularize, we will probably end up doing laser to the periphery just to prevent the occurrence of late recurrences or detachment. Remember that proper screening can prevent these difficult scenarios where you're cursed if you treat them and cursed if you don't. If we inject or if we do laser and the infants come in too late, they might end up losing vision anyway. And the only way to prevent this is proper screening. Finally, in the discussion of the final report of the early treatment of ROP, one of the authors hypothesized that treating ROP could be considered the highest value-based intervention in all of medicine, not just ophthalmology. This owing to the huge impact preserving vision has on the value of human life. Thank you very much.